Hi everyone, welcome to Women's Health with the Listening Midwife. I'm Day Day, aka the Listening Midwife, and today we've got Buki. Whoop, whoop. So Buki is here with us to talk about her birth experience. What's our topic for today?
It will be about pre-eclampsia because that's what I had during my pregnancy. So yeah, excited to talk about that a little bit.
Brilliant. So, Buki, tell us a little bit about yourself. What do you do?
Oh, so I'm a nurse and a midwife as well. Mummy, obviously. Love all things women's health and patient advocacy and teaching nurses and midwives. What else? And that's it, really.
Love it. Thank you so much.
That's all right.
Yeah, I'm really excited to talk today. We have so much ground to cover, don't we?
I know. I was going to say, where do we even start?
There's so much learning that we want to share with you guys, and there's just a lot to unpick. And we want to leave you with some little tips and nuggets about basically advocating for yourself and knowing how to ask the right questions. Really, that's all we want to do here with Women's Health. So, without further ado, shall we get going?
Let's get going.
So, what baby number was this? How was everything? Talk us through the start of your pregnancy.
This was my first baby, surprise pregnancy, but very thankful to God. And the pregnancy started off, I felt bad. I had those, you know what, it was the nausea for me. It was the nausea. It didn't get to the point of hyperemesis, which is where I couldn't eat anything at all, but the eating was very minimal. Like I had no appetite and then would just constantly gagging or wanting to vomit. And that lasted throughout the whole of my pregnancy, all the way up until I delivered, to be honest.
Wow.
It didn't pass,
That's tough. And so, like, with hyperemesis, that's when you get this sort of, consistent urges to vomit, throwing up quite consistently through the pregnancy. Did you notice more saliva? Because this is one of the things actually for women of colour especially, that they have this excessive salivation.
Yeah, I had the excessive salivation. I had the dry mouth, metallic taste. Oof. And then just complete loss of appetite. I think I remember just being on Lucozade, actually, not even water. I couldn't stand water. Wow. It was the Lucozade berry flavor. Do you know how I remember? Because the one person at work who knew would come into work with that and put it on my desk, and I'd be like, just thank God for this person, because this is what's getting me through right now.
Yeah. There's always things that you will remember about your pregnancy that are I loved pickles. I could not stay away from pickles. Pickles and yogurt drink was my thing. I could not stay away. So you always remember something.
Exactly.
Okay. So how was your pregnancy described for you? So when we class women as high risk, low risk, midwife led care or obstetric led care, what pathway were you put on for your pregnancy?
So initially I thought I was going to be low risk. I chose a central London hospital that I had previously trained at. So I love it to bits. Great doctors, great midwives. So I felt comfortable, but also a very medicalized hospital because they have a lot of funding. They do a lot of research.
So this wasn't your local hospital.
This wasn't my local hospital, okay. And I always tell this because in my profession as a fertility nurse, and when women get pregnant, I was like, you can pick whichever hospital you want. You don't need to stick within your local area. Of course, when you're heavily pregnant and you're about to pop, it's nice to know that your hospital is down 10 minutes down the road as opposed to a good 1 hour drive. But I think peace of mind that you're comfortable with the professionals. I mean, that should be in any hospital. But if you've been to a specific hospital before, you felt like they took care of you, you felt like you'll be comfortable there, then choose there. All things given. But it was not my local hospital. It was actually closer to my workplace.
Okay.
And I thought, okay, with the appointments and everything, it'll make sense to be able to go to work and then pop to an appointment.
Perfect. Okay. So I think what I'd like to just remind ladies is that you absolutely have the right to choose where you would like to be cared for. And one of the things that I think we're probably going to cover as well as we talk is be mindful of where, when you do need to go to the local hospital for reasons outside of appointments. So if you need to present to the local maternity triage, in some cases that might need to be your nearest hospital. So bear that in mind about your ability to travel to and from whichever hospital you choose to go to, because absolutely you have that choice to choose where you'd like to go. But bear in mind that, you know, if that is further away for you than your local hospital, then traveling might become an issue, especially as you get more heavily pregnant. So if you are nice and low risk and everything's all right, you know, think back to those kind of decisions into your planning. But also you can change your mind as well. Like you can move hospitals, people move houses, people move locations, and so they move hospitals. And absolutely make sure that if you are moving hospital for whatever reason, that you make sure you've established contact with your new hospital, you've got appointments in line. Don't cancel anything until you have an appointment fixed for your new hospital, so that you don't get lost in the system and there's no kind of missed appointments as a result of that.
I would add that also that you know where your notes are. So I think a lot of hospitals have now moved to like electronic. And if you're not still holding on to your notes, which I kind of miss, then knowing where on the app you can find like all your latest results, or where you can find where they've documented the latest scans and things like that.
And how to print those, because as much as we love going digital and all that kind of fun stuff, it's also sometimes useful to have a copy of your notes, especially if, for example, you're going on holiday, you're going abroad, and you might not have good internet if you need to present to the local maternity unit. So actually sometimes having a copy in those kind of circumstances is really useful. So Buki, we've touched on where to book, local hospitals, things like that. So tell us a little bit more about you, and were you high risk, were you low risk, what pathway were you put on?
So I was initially low risk. I went for my 12-week scan. I think I had it at 13 weeks, and the hospital where I was did a blood test to check for my risk of pre-eclampsia, and that's where it came back as 1 in 100. And they told me to start taking aspirin 150 a day. And then
did they explain to you about that? So that whole kind of, because so just for your awareness, so this blood test that they're talking about, it's not a standard across all units in the country. What you find is that the big research hospitals, so as Buki mentioned, she was booked at one of the biggest, or what we call a tertiary unit. These are the big hospitals in London that have more fun in and around the UK. Really, it's not just London, but they have more funding, more access to research, fellows and clinical fellows, and so they have more money to try more up to date and more sort of evidence research kind of at the forefront of research trials and things like that. So this blood test, it sort of falls under that category. So in my local hospital where I work, we don't offer that kind of test. We use a screening pathway where we look at the woman's characteristics, so age, what number pregnancy this is, and other factors. If she's had previous pre-eclampsia, for example, which is a pregnancy-related blood pressure disease, and all of these factors will help us to decide actually this woman needs to be on a pathway for increased monitoring during the pregnancy. So you were told that you are high risk of getting pre-eclampsia, and you needed to be on aspirin, which is a baby dose of aspirin, 150 milligrams once a night. What did they tell you about that?
He was really good. He's just like, you're higher risk as well because you're African Caribbean. He told me foods and things to stay away from. So, high salty foods. If you're going to drink stuff, drink full fat, don't drink sweeteners. And then that's when he told me to have, try and get a blood pressure machine at home so that I could be monitoring my blood pressure. He told me not to worry, to be honest. And he told me the symptoms to look out for. He also said that if it was going to happen, it would happen in my 2nd to 3rd trimester.
And this is developing pre-eclampsia.
Developing pre-eclampsia specifically. And that they would keep an eye on the baby and bring me back for my next scan at 20 weeks. So that's how it was left. And I was quite comfortable with that, actually.
And so as a routine, so the standard dating scan, which is what happens sort of between 11 and 13 weeks, is they do a risk assessment for all women for if you consent to it, for Down syndrome, Edwards and Patel syndrome. So these are sort of anomalies that can happen during the pregnancy, like genetic conditions, and so we offer that screening. And once you do that screening, you also do another blood test as well that looks at some of your biochemical markers in your blood to see what your risks are for developing these conditions as well. And this additional blood test that Buki had. And they give you lots of information, and then you come back for a scan at 20 weeks, which is called the anomaly scan, where they do a detailed assessment of baby. They look at all the structures within baby, the stomach, the heart, the brain. They do a full assessment, and if it's all normal, that's fine. You get sort of signed off, and if they detect anything, then you go for further investigations and further in-depth scans to assess what could be the reason for those anomalies they spotted. Yeah. Brilliant. So you got a lot of good information, it sounds like. They were very good at explaining that to you. And so some of the ways that aspirin works. So the reason why we would advise women who may be at higher risk of developing preeclampsia to take aspirin is because the evidence shows that aspirin can support with reducing the resistance and the blood flow from the mum to the baby. So all the blood flow to and from the baby, we try to minimize any resistance, because we think that actually preeclampsia is caused by the way the placenta embeds into the uterus, and therefore it might not work as effectively, and that can start quite early in the pregnancy. So with the help of aspirin, the evidence shows that can minimize any kind of high resistance that would cause problems with blood flow to and from baby, and therefore those blood flow problems can be associated with baby not growing to their full potential. So they might be what we call small for their gestational age as they develop, risk of preeclampsia and other kind of complications as well. That sounds about right.
That sounds right. And then I went on to have my 20-week scan. Fine. I think because of the preeclampsia thing, so I think standardly you don't get many scans throughout pregnancy anymore, but then it triggered I got way more than normal, which was fine, because I thought it was more chances to see the baby, but the baby was just hiding anyway.
You get more chances to see, and the baby's like, nope.
And I think it was around my 28-week scan that they were like, okay, baby's a bit smaller, and they measured my uterine Dopplers, and they found that the resistance was high.
Okay. So that's the uterine artery Dopplers. This is measuring more in depth the blood flow from the uterus, from mum to baby. And as I said, if there's higher resistance, then that is an increased chance of baby being small, which is what happened. Very, I think, classical presentation of of preeclampsia. And I just thought, I wasn't a big baby anyway, so it doesn't matter that my baby will be small. I didn't think anything of it. And then the next thing, so all throughout this I was still having like really bad sickness, couldn't really eat. So I thought that was the reason why the baby wasn't big. I didn't really think it was a placenta thing. But the next point was at around 34 weeks when I had like a headache all day, and I thought, okay, what is happening here? I was lying down all day. I didn't feel like I'd been stressed, drinking loads of water, took paracetamol, and it got to about 10 p.m. and I was like, babe, you need to take me to the hospital. And that's where your point comes in. I went to my nearest local hospital as opposed to the hospital where I had been booked and had planned to deliver. Okay. And so for your understanding, for women out there, actually, you can get headaches in pregnancy, and they can just be headaches in pregnancy. But I think when you just have to be more aware of what else is going on. So Buki was aware that she already had a smaller baby on board. She knew that she was at high risk of preeclampsia as well. And she knew about the symptoms, which can include, that headache, especially frontal headaches. I don't know where your headaches were. Sometimes it's just all over, but generally more associated with preeclampsia is these frontal headaches right behind the eyes. Quite throbbing all over as well. And you might get swelling in your hands and feet that might be quite sudden, it might not be. You might notice your face gets more swollen over quite a short period of time, and swelling in your feet and your legs as well. So this that can be a sign. You might get this pain as well, what's called epigastric pain, so left upper quadrant pains. And sometimes that can be associated with raised blood pressure problems. You might get none of the symptoms, actually. And Buki didn't have any symptoms until she had symptoms.
Exactly.
Which is not helpful. I'm sorry. It's like that sometimes.
And also because of the swelling of the feet, you get the big nose, you get the swelling of the feet, you think, okay, this is just the norm. But I think
it can be if you spent the whole day on your feet. Well, actually, you're probably going to get a little bit of swelling. And I think it's about kind of differentiating between, okay, I have laid down after being on my feet all day, and I have elevated, and I've done, it's still there. I've done all these movements and exercises they told me to, I'm drinking well, and it's just something else is going on. And even if you're not sure, like always contact your triage and speak to them and explain some of your background risks as well. if you're a woman of color, explain that you're a woman of color, because we know that from the evidence and the research, like we're 4 times more likely to die and have adverse outcomes in pregnancy. So we need to be advocating for ourselves and going, look, I'm a woman of color. I know that I'm at higher risk of preeclampsia because I had this test early in pregnancy. I'm on a scanning pathway, and I'm concerned that I might have this headache now, or I'm concerned that I might have this other symptom. And don't get fobbed off. Like, you know, as a healthcare professional, we're not there to fob you off. Let me tell you, we'll come to do, give our very best. But sometimes, you know, in the chaos of the day, it's busy, we're running around, and sometimes it's like, oh, you know, just try this, try what they've asked you to try. Like you said, you know, you had your paracetamol,
you're drinking water,
sleeping in a dark room, rested, everything. You did all the things you're supposed to do. And so, you know, at the point where you're if you're feeling like you've had to contact the hospital, that, you know, we need to be taking you seriously. So just say to them, I'm coming in because X, Y, and Z. And, you know, be bold.
And it honestly, like the bare minimum of an investigation is doing your observations and checking your blood pressure. Like, and then monitoring the baby. That's the bare minimum. And I think it's something so simple, but can be so helpful in your journey, especially when detecting preeclampsia.
Yes. Yeah. Brilliant. And so then you thought, well, actually, I need to go to the hospital, and you made your way to the hospital.
Yeah. And when I went to my local hospital, obviously, because all my notes were on my app, on my phone, it was a problem.
Digital, woo!
It was a problem. I was like, I have everything you need. I can give you my phone. I've logged in. I can tell you what you need when you need it. Like, I can show you. I wasn't in love with the care that I got there, but it was immediate care. They did my blood pressure. It was high. They started me on a tablet called nifedipine.
Okay. Nifedipine first?
Yes. Okay. Nifedipine first.
Okay.
I was there all night. So they gave it to me. I think I waited like 4 hours. It took a long time for my blood pressure to come back down. They did a CTG. They monitored the baby. Baby was fine, but it did show that I was having like light contractions, but I wasn't feeling any of it.
Okay.
And then they sent me home with one more tablet.
Just one tablet?
Yeah, and this was a Friday night.
And so what was
and a prescription.
And what was the follow-up plan?
Oh, go to my booked hospital.
Okay.
that was the plan. Go to my booked hospital. I spent the next morning. So they gave me the nifedipine BD. So I spent the next morning because I had the tablet. Sorry. They gave me the nifedipine twice a day. Yeah. So I had my tablet for the morning, and then I had a prescription so I needed to go around and find pharmacies that had the nifedipine, so I could start taking it regularly. So take my evening dose that Saturday night, and then my Sunday and Monday. So that was probably the most difficult part, because I literally remember being in my dressing gown, shattered because I hadn't slept, with my mum driving around to pharmacies because nifedipine wasn't in stock in the majority of pharmacies on a Saturday. So that was difficult.
Yeah, that sounds not great.
I know.
But, you know, we listen, we don't judge.
We don't judge. And in that moment in time, I was just like, let's just get my blood pressure down. Let's just get it controlled. And I was so reassured that I was just going to pop into my hospital on the Monday.
Yeah.
Which is what I did. And they were great.
So did you ever get hold of that nifedipine?
I did eventually. Okay. After, I think it was 3 pharmacies later. Yeah.
Okay. Oh, that didn't help your blood pressure.
Do you know? It was just like a more of a mental booking.
Yeah.
Stay chill. Cool. Like, it's
sometimes you have to, in your pregnancies, or you have to really talk to yourself.
You have to mentally talk to yourself. Yeah.
Just don't lose it. Don't lose it. Think of the baby.
Exactly. That was where I was at. Okay. But yeah, I did eventually get hold of it.
Okay. So you already knew I was going to ask you what the red flags are, but I think we've covered that. We know what the red flags were in terms of, you know, that throbbing headache. We already had that risk assessment in the background that was kind of telling us to be more aware of our symptoms and things like that. And so I guess what happened next then for you? What was the next step then when you went back to your local hospital with all not your local, your booked hospital?
I booked.
With your symptoms. And telling them that, oh, look, listen, I went to this local hospital and this was the management plan. What was their sort of feedback? Do you remember?
Yeah, I do remember. I was there probably for like half a day. They scanned me. They did a CTG. I spoke to the consultant. Again, the baby's growth baby had grown, but not a lot.
And can I just ask, was this an appointment that was scheduled for you, or was it in between, or you just went to the assessment unit?
I went to my own medical, the assessment unit there to say that like, this is what's happened over the weekend.
Yeah, okay.
And they just swooped me up. I did a blood pressure, they checked my urine, they did a CTG, they let the consultant know. I went to the fetal medicine unit.
Okay.
Yeah. They did another detailed scan, and then they were like, "Well, this is where we're at the moment. Your baby has, well, SGA, so small for gestational age. You're showing signs. You have preeclampsia now because they took bloods as well to check my liver function.
Yeah.
So you now are diagnosed with preeclampsia. They started me on labetalol, so a second tablet.
Okay.
Because even though my blood pressure had come down, it stayed like borderline in the 140s, over 90s.
And did you said they checked your urine? Was there anything in your urine?
No.
Okay.
There was nothing in my urine, interestingly.
What were they looking for? Tell us as from your midwife.
If I remember. Protein? There's protein in it.
Yeah, so essentially when women, well, in every midwife appointment, you'll have your blood pressure and your urine checked. And as part of that, they will be looking for sugar and protein primarily. You might have more kind of complex sticks that will pick up things like any signs of urine infection, all of that other bits in there. But the main things for pregnant women we're looking at is there any signs of sugar, which can be an indication of diabetes, or is there any sign of protein, which can be a sign that you might be leading to develop preeclampsia. So in these cases, as preeclampsia can affect all of your body systems really, but primarily we know that if your liver function starts to get a bit deranged, or your kidney function starts to get a bit deranged, that's more closely associated with preeclampsia. And so that's why they will do the blood test to check your liver function, and they'll do a blood test to check your kidney function, as well as do your blood pressure and the urine dipstick. So when they dip the urine, if there is protein in it, then they will send it off to measure how much protein is in the urine. And that, again, can be used as a measure to say, okay, yes, you are full-blown preeclampsia, or, it's what we call fulminating. It's, you might be developing it. You're getting there, and, you've got all these other symptoms. So we need to be monitoring you and baby more closely.
Yeah. And that's basically what happened. And they booked me in for another scan in a week's time.
Okay. And so they booked you for a scan in a week's time. I'm assuming that was to check the blood flow. That was a blood flow study.
Yeah, they checked blood flow again at 34 weeks. I think the resistance was similar. And then they said, okay, we're going to rescan you in a week to check baby's growth. Keep an eye on your blood pressure. Again, you try and Dopplers.
Yeah. So what they normally do is with growth scans, they like to leave 14 days in between growth scans, but they can monitor the blood flow more regularly. So they can do that weekly and even closer if they're starting to see changes in, the way the baby is compensating with those blood flows. And so, they measure the blood flow in the brain as well as through the umbilical cord. So that's your baby's cord, as well as the uterine artery blood flow as well through to the baby. So they do lots and lots of comprehensive blood flow studies to check all the resistance and the pressures in the blood flow.
So again, that one was fine at 35 weeks, and then so they booked me in for another one, and that one was like the proper growth check. And they were like, okay, in 2 weeks your baby has not grown. At 34 weeks he was 4 pounds, at 36 weeks he was 4 pounds. My Dopplers were still the same.
Okay.
My blood was stable, but my blood pressure was up and down. Well, I was like, you've just told me this news, and I'm taking my blood pressure. I thought it was going to be high, but so they kept me in that night. Had emergency section the next morning.
Oh wow! Oh well, that was quick. The end. Okay. Well,
to be fair, they did give me. He talked me through it. I was in the fetal medicine unit at this point, so not midwife led, definitely consultant led, but strictly fetal medicine. And they were really good. Like, we can induce you. You can have a section. We can wait if you would. Like, they
give options.
They took me through all of the options. I think it was my midwife brain, and I feel like in my head I was like, well, he hasn't grown in the last 2 weeks. What is waiting going to do? My blood pressure is already high. Why would I put stress on my body through contractions? Why would I put stress on the baby from the contractions? Let's just have a section. Let's get the baby out. Let's beat him.
I think fatten him up on the outside. That's my motto.
That was my one goal.
Good.
But otherwise, I can't fault the hospital in terms of communication. That was really good. But I knew it was going to be, and I think that's why I chose that hospital.
Good.
So
I love that. I like when we have a good experience of care, and that we'll never get it 100% because the NHS. We know the state of the NHS and all of that, but to hear where things have been managed well, even though you had the hiccup with your local hospital, that it still sounds like actually when you got in there, they were quick to kind of go, right, we know what's going on here, we know the pathway that we need to follow, and this is what we need to do. And maybe the management of your discharge could have been there's room for improvement. We're all here to learn and improve. There's room for improvement there, but it looks like actually, you know, the management up to that point was quite good.
It was.
Okay. So you had a baby.
I had a baby.
So you opted for a cesarean section.
I did.
Okay. And so did you feel like part of, it sounds like you were kind of well informed throughout, but did you feel part of that decision-making process and feel like you had a choice and a say in what happened?
100%.
Love that. Okay.
My partner, on the other hand, was like, wait, this is going too quickly. I think as females, you've already thought through, like, okay, this could happen, that could happen, that could happen. What would I prefer? Blah, 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 blah. So I'd already thought through that process in my mind. On top of the fact that I'm a midwife, so I had the clinical knowledge.
Yeah.
Whereas he was like, huh?
Yeah. He needed a whole week to get
to digest.
Yeah. So I think like one of the things I just want to mention is that how you do have options actually in situations like this. So how many weeks were you?
I was 36 plus 5 when I delivered.
So like, you know, right, just skate into next term. So what we call term is 37 to 42 weeks. And if your baby's born in that time spontaneously, naturally, we're like, yay, wonderful, go, we'll look after baby. But if it's a little bit before that, then, you know, we have to consider other risk factors as well, because obviously a small baby that's slightly below will need a little bit more support and help postnatally, especially with just general things like keeping warm, maintaining their feeds, and because they get tired easily as well when they're smaller and when they're a little bit earlier, so they don't necessarily like feed for as long as they need to get the same amount of nutrients that they need. So, you know, those are the things that we look out for when you've got a smaller baby and a baby who is, you know, slightly premature, and keeping them warm, and they have a slightly higher risk of jaundice as well. So these are the kind of reasons why, you know, we as much as possible, we want to get you to past 37 weeks, but we have to balance between what is the safest option for mum and baby. And if you've got a blood pressure that keeps bouncing up and down, that's not good for your brain, and that can increase your risk of strokes. And if you've got a baby that isn't growing as well as it could because there's a potential problem with the way the placenta is being able to feed that baby, then actually, you know, is it safer to get baby out and fatten them up on the outside? So, you know, these are the discussions that that you should be having with your team to say, all right, okay, well, this is where I'm at, this is how I feel, this is what I would like. And induction can sometimes be an appropriate option if that's what you want. And sometimes actually we know that I don't know if you've ever experienced it, but sometimes the ladies with pre-eclampsia tend to just
quick.
Their bodies are like, good, finally, let's get on with it. Let's labour and let's get this baby out. And they actually sometimes, not all the time, can't say all the time, but they do tend to progress quite well. But obviously the babies don't have the same amount of fat and reserves to deal with the stress of labour. So you might find that they're more likely to get distressed during the labour process, especially if they have to be induced. Your body needs to be put into labour, and therefore that can increase the chance of you needing an emergency cesarean section because the babies aren't coping with the stress of labour. So you weighed all those decisions with all your knowledge. You were like, I've seen this 100 times. I know all the different ways it can go, and your partner was like, what? literally. So he's like, babe, I trust you. So you opted for an elective cesarean section.
Correct.
And how was it?
Good. Good. I remember feeling cold in the theatre, but otherwise the team were lovely. They took my partner's phone, they took pictures when he came out. Good. That was good. It was more the afterwards, obviously, because, you know, as a midwife, they're like, skin to skin, baby on breast, all of that bubble phase that I did not have.
And why didn't you have that?
Because he was tiny, so they had to do his checks, and then I was very cold for some reason. So if I'm really cold, they didn't want to do skin to skin. So it was his dad. Even better, it was his dad who did skin to skin with him, which is lovely. Which is lovely. But he wasn't maintaining his temperature if he was off the skin. So when he was in his clothes or when he was wrapped up in the little cot, he was not maintaining his temperature.
How much did he weigh?
He was 4 pounds, so he was 1.9
Oh, so he
kg.
was bang on the scans.
The scans were correct in terms of estimated
Wow.
fetal weight.
Because
Yeah.
there is variation with scanning. Obviously, you sort of, there's no fixed percentage, but generally you have a margin of error which can be anything from up to 10 to 20%, especially as you get closer to the end of pregnancy, and babies get bigger and it gets harder to measure and to scan them in certain positions. So sometimes you get a sort of larger margin of error, but it sounds like in this case they were very, very spot on.
No, spot on.
Yeah.
My
So
last
4
scan said
pounds.
1.9. Yeah, he was a small baby.
1.9 kilos.
Yeah, literally, you could just hold
That's 2
him.
bags of sugar.
He could hold him in one
Pocket
arm.
size.
Exactly.
Oh.
Exactly. So yeah, he wasn't maintaining his temperature. I had my section, obviously, and so couldn't move. I was just like a sitting duck in the bed. And then they felt like they took blood just to check his levels. Felt like he was a bit jaundiced. And his blood kept clotting. That was another thing. They were taking the blood, but it kept clotting. So they're like,
run the
too
samples,
sticky. Yeah,
just because they thought it was just too sticky. And
even before they said they would send one sample, it came back as they couldn't run it because it had clotted. They tried another one, similar results. So they ran a VBG or ABG. It was quicker. Blood gas. There we go. And that came back with the jaundice levels and things like that. So they're like, do you know what? We have to take him to NICU.
Yeah.
And that was heartbreaking. And that was when I was just like, if this was in the evening, I was like, I can feel my legs. I know I can get out of bed.
Yeah.
Get me out of bed.
There's nothing more motivated than a woman who has a baby in the neonatal unit. She's going to get up out of bed. And the smokers, they're always very, very mobile, very quickly. So yeah, women with babies in NICU and women who who have their babies separated from them because they have to go to the neonatal unit, they will go above and beyond. You find it deep down.
You get out of that bed. Yeah. And I was like to my partner, find a wheelchair, take me downstairs.
I can imagine how hard it is to be separated from your newborn baby.
From your newborn. Yeah. So that, I think that was probably a bit, I was in autopilot throughout the pregnancy. I was just like, let's just get there. I need to keep him growing. Let's get him out when it's the right time. We got him out. Then that's when I think I had my emotional meltdown every time I went down to the NICU.
Yeah.
But he's fine now. You should see him. He's
How old is he now?
15 months.
15 months.
I know. Oh. You should see him. He's such a character. He's such a personality. He's like a strong and mighty, small and mighty is what I call him. Yeah. Because he's still smaller for his age, for other 15 months, but he will push everyone out of the way. Yeah. So, very thankful.
Oh. So I think the next question I have for you was how did you facilitate bonding with your baby while you were separated from your baby? Because I imagine that can be quite difficult emotionally, physically as well. You're recovering from a cesarean, all of it's going on, emotional.
Yeah, it was a combination of everything, really. I suppose the first part is it gives you strength because, like you said, you find the way to get out of bed. I think after a C-section, you're scared of the pain, you're scared of all of that, but then actually, and you just want to lie in bed and feel like, okay, let me wait for the pain to pass. But really, you should be trying to get up after about a good 24 hours. You should be trying to get out of bed and get moving. So I think that was really helpful. I pushed myself, I think probably about at 12 hours or 10, 11 hours. I was like, I'm out of bed now. But that was really helpful. But then taking pictures. So my mum took loads of pictures when he was down in NICU. He had jaundice. So he had like the blue billy lights. He had like a little mask thing over his eyes, so you couldn't really wires everywhere, so like typical presentation of like a baby in an incubator. But still looking at pictures of him was really helpful for me. I had like a little muslin that I had holding with me around my chest, so then I would take that down and I'll put that in his incubator. So like little things like that were really helpful.
Yeah definitely. Okay. And did you choose to breastfeed? Was that your plan? Do
you know what? I think so. I was just going month by month, day by day in the pregnancy. I hadn't really, and because I knew it might have ended up in the section, I hadn't really put like pen and paper down for a birth plan in terms of this is what I want, this is what I don't want. I would have loved to have breastfed, but when he came out, he was on fluids only, so he wasn't having anything via the mouth. And then I was just like, actually, I just want him fed. So even if he's not having my breast milk, then at least have some sort of milk. But there was a transitional care nurse who is like a nurse who looks after babies when they've come up from postnatal from NICU, but also looks after the mums when the babies are in NICU and the mums are still on the ward. She was amazing. And she was like, you need to start hand expressing. You know, all the stuff that I already knew because I was a midwife, but I wasn't in the mental space to act on it. She helped me act upon it, and was really good with reassuring my mum as well that like I would get there, because that's a cultural aspect of, you know, come on, get up, breastfeed your baby type thing. My mum was great, but you have that cultural aspect as well. She was she was a really good in between in terms of reassuring my mum, reassuring me, and being like, you need to do this every 3 hours. Tomorrow, get on the pump, even if you're not seeing anything. Get on the pump. And then I went on the pump. Oh my god, and colostrum was coming out, and I still till this day have the picture on my phone, because I love pictures, because they just remind you of where you've been and how far you've come. And I was just like, oh my god, I'm starting to see milk. So then when he did come up, he was having half express milk and then half of bottle of the formula. And then eventually, by the time we were getting home, he was doing majority of express milk. So
amazing.
Yeah, and I think that's one of the take homes, is that, you know, even if you can't get baby on the breast and feeding, because there is a lot of emphasis on baby going on the breast and feeding and sucking, amazing, beautiful, great. You're not a failure if you can't do that. You know, emphasis is on the baby being fed, but also you can express your milk and give to your baby via a bottle. I mean, at about 6, 7, 8 months, I was tired. I was not tired of expressing, but I just didn't have energy to express one night, and I put him there, and he started sucking. So he started.
He's like, I'll take it however
it comes. And he went on, you know. So I did breastfeed him eventually.
And
I had to wean him off.
That's the harder part.
So
no one talks about weaning them off.
No one talks about weaning off. So I think everybody's journey is so different. It might not start off as you think it would, with, you know, your baby on your chest, skin to skin, breastfeeding, sucking really well, you know, great attachment, great latch, all of that jazz. But, you know, like I said, he went on later on, and, you know, I got the best of both worlds. I expressed, I gave bottle, he breastfed.
I think what I just want to highlight to women as well is that it can be a bumpy kind of
100%
entrance for baby and for you through that period, but you can have your baby moon. You can absolutely like recreate that wonderful magical moment you want. You might not have the home birth you want, you might not have the vaginal birth you want, you know, you might not have had the cesarean section you wanted because everything happened too fast, but you can, you know, create that environment for yourself and your baby once you are settled back home and have what we call a baby moon. And I think it's like, I don't want to belittle anyone's experience ever, because you have to feel what you're feeling about your birth experience, and sometimes talking through it is really, really good. You know, and getting these postnatal debrief appointments in the hospital, if you can arrange that and facilitate that, absolutely do that if you need that. But take the time to treasure those moments with baby whenever you get to that point, because I'm sure you would have felt like you missed out on the first day, you missed out on all of those lovely skin moments, and you know, all of that. But you, like what you said, you got to do that, and it's so special to be able to do that.
And it's easy for me to sit here because I've got retrospect. You know, I'm looking back on the past 15 months. But one thing I would say is, don't put too much pressure on yourself and on the baby. Like, these things that you know, the NHS, they're all guidelines. They're, you know, they're guidelines, preferences if it's for mother, but actually you never know. Your baby might be slightly different. Your baby might not take to this. You might not take to that. You know, there's so many things. So allow flexibility in every single day, and how you care for the baby, on how the baby responds to you, and you learn so much and you grow so much daily, as opposed to, this is what should happen and it's not happening, what's wrong with me, what's wrong with my baby. I feel like that tends to be the narrative, and actually there isn't anything wrong, but you guys are individuals and you're learning from each other. You're figuring it out.
Every mum and every baby is different.
Exactly.
The standard thing that's done for thousands of women might not work for you and your baby.
Exactly.
And, you know, you might get back around to it, maybe, but, you know, you just have to navigate that and figure out what works for you and your baby. You know, and that's what, you know, as much as possible, midwives will try and do, especially in the community once you're settled back home, is to kind of give you that individualized, kind of personalized care at home.
Yeah, agreed.
So, to round off then, how was your blood pressure after that?
Oh, my blood pressure.
Was that number 3?
I was on the tablets for ages. I think I eventually came off them at about 7 weeks.
Wow.
Postpartum. And even now, I'm so completely mindful of like my stressors in daily life. keeping my blood pressure down. Like I don't want it to turn into pre-eclampsia because it was in pregnancy, and then like hypertension now that outside of pregnancy, and believing God for more children down the line. And we know that if you have pre-eclampsia in your first pregnancy, the likelihood of you getting it in the second pregnancy is high. So for me, once I got off the tablets after 7 weeks, I'm like, okay, what lifestyle changes can I make that I can that are going to be significant enough to try and optimize my health long term. I'm not naive to the fact that I had daily stressors just from family life, but just managing other things was really important.
Lovely. I love that. So really we need to be thinking about holistic care, because preeclampsia in pregnancy, you can be more prone to hypertensive disease as you get older in life as well. So it's about making those changes now while you're still young. Youngish. But making those changes now so that actually you can optimize your health, improve your life, and reduce your chance of you developing hypertension and other sort of cardiovascular diseases later on in life. So it sounds like you're on the ball there. So
I'm trying.
working towards it.
Work in progress.
Always. So great. Okay, so just to wrap up then, I think what would you want women to think about and to be able to talk about and do if they found themselves in a situation similar to yours?
Yeah, sure. First thing was to make sure you pick a hospital you're comfortable with, that you've read the reviews on. Go and visit the hospital if they offer you a tour, so you can be used to the space and so you can feel at ease. I think is the most the term that I'd like to use. Ask questions. Like, no question is too silly, and no question will give you a better answer than a health professional in person than going to Google, because interpretation on Google can sometimes be a bit wrong. I'm not saying the information is wrong, but how it applies to you yourself specifically can be wrong. So actually asking that question to a health professional, the person who's seen you, the person who has scanned you, the person who can see all your information, and make a judgment or recommendation is better. No question is too silly. And no symptom, because I think one of the biggest things that I struggled with was the reduced fetal movements, because they talk about fetal movements being like the biggest indicator of fetal well-being, basically. But
absolutely.
And I used to talk about that a lot as a midwife, but now that I've been pregnant, you don't remember. You actually don't remember how much your baby moved throughout the day, or how many movements, or it's almost the pattern of movements. I genuinely couldn't. I know that he moved more at night than he did during the day, but sometimes I'd literally have to poke him and see if he poked back. That was my way. That was my way.
It's okay to poke your baby.
I mean, it wasn't a hard, it was just like a...
I used to do that. You just sort of
a gentle press,
press on one side, wherever you know that you might find a foot.
Press to see if you that is how because I couldn't, that whole, I think more work needs to be done on that, like fetal movements, the pattern, and things like that.
And fetal reactions as well. Like you say, like poking a baby, you're trying to elicit a response from your baby. So that's why we always say to women, because babies sleep. They have sleep and wake cycles.
Yeah, they do.
And that starts from, I don't even know, I think like 28 weeks. So it starts quite early, because that's what we see when we're monitoring babies' heart rates on what we call the CTG. You do see that they can have sleep cycles and wake cycles. You see the sympathetic system and the parasympathetic system working. And that's why you get, the up and down traces. And when they're sleeping, it's the up and down is a lot sort of a thinner line, and then you get these big kind of ups and downs when they're more active and when they're moving and all of that. So actually you want to elicit a response. So we say drink something cold, drink something hot, lie down and do nothing, because that's when they're like, okay, it's our turn now, we can dance. Like all of this, just be that as well, increase your awareness. So stop for a little while and actually pay attention to what your body and what's happening, because you might have missed all those movements just because you've been busy up and about.
I think that was what was happening with me. It wasn't the fact that, it was the fact that he moves more at night than he does during the day, but that I was so busy even still at night that I wasn't picking it up. So I was just like, oh gosh, do I go in for a CTG? When they asked that question, regular female, I was like, I don't know. Might as well just do might as well. And it's okay to be like that as well. It's okay to not know. Because then you can get checked out. I think it's always play on the safer side, as opposed to not, or thinking that actually that's silly. I'm sure he's moved today, and that will probably be my take home.
Lovely. Thank you very much for
Thank you for
sharing your
having
birth
me.
experience.
Thank you for having me. It's been a pleasure.
I'm gonna have to bring you back. 'Cause I feel like, you know,
I've had fun.
Yeah. We've had a laugh, and you know, like there's so much that you're doing with women's health, and you know, in your role as a fertility nurse,
and
so
menstrual health,
so,
that'd be cool.
menstrual health, like this. So yeah, you're going to see more of her. So yeah, love this space, and obviously, if you haven't already, like, subscribe, share, tell people about it, and let's get women educated and informed about their pregnancies and beyond. Thank you very much.
Thank you. Bye.